You see this partner, one is sleeping and other couldn't. So how is the life? They are not happy, at least in the morning, because the wife told that I couldn't sleep in the night. Sleep, by definition, is the state of unconsciousness for some time, for some hours. External stimulus could not be taken by the person. But in other words, being a doctor, if I want to say something, that it is the hypothalamus that is regulating the pattern of the GABA and acetylcholine, which is working more. So in that state, if you consider an infant can sleep 16 to 18 hours with REM of 50% of their sleep, but an elderly only 6 hours, sometimes no REM. So this is the lifetime we have passed. In this room, there are many more than 60 years of age person, they experience insomnia, including myself. So how our wake system is being monitored? You can see the norepinephrine, serotonin, acetylcholine, histamine, and orexin. These are the substances make us awake, because now we are listening, all the system is working now. The other system which make us sleep is adenosine, and very important is GABA, galanin, and from the pineal gland is melatonin. There are many stages throughout our life. We can sleep only 1/3 of our whole lifetime. 2/3 we remain awake. Many people, even they couldn't. So, if we consider the non-REM sleep and regular eye movement sleep, that is the best part of the sleep, and that is, we dream at that part. So if you think that I dreamed last night, it means you had REM sleep, and that is very important. Ladies and gentlemen, there are so many sleep disorders, but today I will talk to you only insomnia. This is the part that is very important. It is defined as difficulty with initiation, maintenance, duration, or quality of sleep that results in the impairment of daytime function. That means the patient is not feeling well in the daytime. So many things. In one line, patient feels dissatisfaction with the sleep in the term of quality and quantity both. DSM has given some classification that dissatisfaction can be like this: difficulty in falling asleep in the daytime, difficulty staying, cannot. So repeatedly the sleep broke in the night, and very early morning the sleep broke and got up from the bed. Insomnia is not sleep deprivation. It's very important. You have to understand that sleep deprivation is inadequate ability to sleep. Adequate ability to sleep, but there is no time, inadequate opportunity. On the other hand, insomnia, you have enough time, so adequate opportunity, but inadequate ability. So these two terminology are very important to understand. Why insomnia? Insomnia is not a simple symptom. It's a disorder as evidenced by unique set of physiological changes within the body and associated with impairment of function and quality of life. The prevalence, you can see, more than 33%, or that means 1/3 of our population, adult, experience insomnia intermittently or continuously, whatever may be, but this is very important. And for this reason, in many parts of the world, the sleep drugs the increment of prescription has been increased to 300%. And this is very alarming for all of us being doctors. So, if we consider why there is insomnia, there are few things that you can see. The perpetuation or perpetuating factors, precipitating factors, and predisposing factors. You are thinking that these are almost all similar terminologies. No. This can affect the acute insomnia, early insomnia, and chronic insomnia. So, perpetuating factors, there are many, but I have highlighted only 2-3. Caffeine. Many have the habit of taking coffee in the night, then too much alcohol, in the noise. These are the important. Other than this, whether the bedroom is dark or not, so many factors are there that is affecting our sleep, and there is insomnia. You can see here, if you take coffee at 12 noon today, the level in the midnight will be almost 40% in your blood. So can you think that this is, somebody is on coffee always, and they are very irritable, and they are telling. So when we will talk on history, that time you will see those. Some comorbid condition, psychiatric disorder. This is something like the both other side of the coin. Some psychiatric factors affect sleep, and when there is no sleep, insomnia, some psychiatric factor develop. So, the most important is drug abuse, psychiatric disorder, alcohol, dysthymia, major depression, and anxiety disorder. Some of the systemic diseases that is causing insomnia, of them cardiovascular is number one, and the next is musculoskeletal system, and there are so many others. There are some class of insomnia: psychophysiologic, paradoxic, inadequate sleep hygiene, and insomnia due to some medical condition. But if you think about types of insomnia, transient, short-term, and chronic. Less than 4-week insomnia is transient because of some office, home, personal problem, it can go. But if it is short-term, it is more than 4 weeks, but it may remain up to 6 months, and chronic is more than 6 months. So this is very important. You can judge yourself, where are you? Sleep subdivision is not that much important, but it is just for your knowledge that onset, then maintenance, offset, and also restorative sleep is very important. Otherwise, you cannot have good sleep in the night. So many symptoms can develop, but mainly fatigue, daytime somnolence or sleepiness, mood change. I told you that this happens in both sides. Poor attention to the work, lack of energy, anxiety, poor social function. Very important. If there is insomnia, the people will complain of headache. For that reason, the person will take coffee, and then coffee will take away the sleep. So this is another vicious cycle is going on. People seems like there is headache, so let us have a cup of coffee. Okay. If there is a person coming to you and asking that I don't have any sleep, either acute, short, and chronic, whatever may be, in those cases, history taking is very important. I told you, and these are the very important that you can talk with the patient primarily in the clinical history. And you ask the patient the timing, sleep schedule, what is the environment, what is your habit, everything. And this is important. Why? Otherwise, you cannot judge whether you will, what type of management you will give to the patient. For diagnosis, there is a very good chart. I'm not sure that it can be seen from the audience. There are 7 points you can ask the patient, and there are five options the patient can tell to you from 0 to 4. So the highest point you can get from the patient is 7 into 4 is 28. So I'm not going into the detail because it will take time. If the patient is 0 to 7, the patient has no insomnia, and in a study it has been seen almost 57% of the people, they do not suffer from insomnia. That I told you earlier, 33% they are insomnic. So who are those? Mild, moderate and severe. You can see mild is 23% and their score is 8 to 14. Moderate is 14.7%, their score is 15 to 21, and severe is only 5%. In some data or study, they tell that it can be 10% or 9%, something like that. So, what is the cause of insomnia? There are so many. So, I have taken few. Age, because I told you that with the age, divorce, marital separation, fired from the job, after retirement, change in financial status, outstanding personal achievement, and changing personal habits, and last but not the least, midnight cell phone. Either you are on the Facebook, or you are on the on-call, or whatever may be. But this is very, very important. Now, some substance produces, I have told you the alcohol and caffeine, but there are some drugs we are writing for the patient. This is SSRI and SNRI, both. So, antidepressant drug also causing insomnia. As corticosteroid, decongestant in the nasal cavity, sometimes we use, and this pseudoephedrine, it causes insomnia. Interestingly, beta agonist and beta antagonist, both they causes insomnia. Statins and some stimulants drugs and dopamine agonist. Any drug that crosses the blood-brain barrier above, that can affect the neurotransmitter, and the acetylcholine and GABA balance will be lost. That is very important. You see, this gentleman cannot sleep, insomnic, so many phases of insomnia, and what they're doing, the yawning they are doing because they couldn't sleep in the night. The consequence is very bad because there is no sleep in the night, but after that, the patient is having mood disturbance, but they have gone to the work, they can have an accident, interpersonal difficulties with the family, friends. Many consequences can happen if they become irritable and had insomnia for a long time. So, Mr. Chair and dear audience, I'm almost at the end of my lecture. How will you manage the patient? There are two methods. One is non-pharmacological, another is pharmacological treatment. So, non-pharmacological is the best one if you try first, because sleep hygiene, sleep restriction, in the daytime you should not. Cognitive therapy, behavioral therapy, so total cognitive behavioral therapy. We internists, sometimes we do not know this properly, so better to send it to the psychiatrist. That is the very important. Do relaxation and paradoxical intention. That is very important. This is the CBT. I will not go into the detail of those. Sometimes in some online CBT you can do, this is in the United States available. They have 24/7 availability, so this is possible. And relaxation training, obviously, I can tell the patient very nicely, do physical activities, avoid daytime sleep, and so many things. At least you should be waiting for the night sleep. And that is the most important for which you are waiting. And the GABA is the receptor, and this receptor, they have got the benzodiazepine agonist activity. So you see the long list of benzodiazepine. They have different onset of action and duration of action. So this is written in the book, but I think this is being used also. But non-benzodiazepine are safer than benzodiazepine, because benz can produce habit, dependency, and many others. You can see most ultra short is the midazolam. It is being used for patient is restless, we have to do the MRI or CT scan. Okay, you give IV, very short acting, and it will be excreted in the urine. It is not, half-life is not too long. But there are some drugs, the half-life is long, and we are in Bangladesh, our doctors are prescribing clonazepam, aiming that the patient is having sleep problem with anxiety disorder. Okay, write down 0.5 milligram. But the patient gradually increase the dose by himself, and they become dependent on that. But non-benzodiazepine is gelapion and zolpidem. These two are very good drug, not addict forming. This is the orexin antagonist. You know, this can produce sleep. These are the newer drugs coming. I don't have too much the detail about this, but when this drug will come, I think the others' place will be shortened, and we will. In conclusion, Mr. Chair, insomnia is not a symptom. Insomnia is a disorder, and hypnotics generally helpful, although effect do not appears to be durable after discontinuation. So patient become dependent on that. So cognitive behavioral therapy should be the first approach. The pearl of today's talk. Newer hypnotics are safe. Insomnia often requires multimodal and multidisciplinary approach. There are, until recently, there are no data from RCT lasting longer than, you should not prescribe lifelong or continue this drug. It is better to write down 2 months, 3 months, 8 or to 12 weeks. So it is better to limit the drug that the patient should improve and discontinue the drug. There is limited evidence that antidepressant actually improves the sleep. No. Some patients with dementia and Parkinson's disease, actually they are insomnic, so they require the drugs, and this is very important. A good laugh and a long sleep are the two best cure for anything. Lastly, sleep is the golden chain that ties health and our bodies together. Thank you, ladies and gentlemen. Thank you, Mr. Chair.